Good evening, everyone, and welcome to today's session. So, my name is Teresa Mundia, and I'll be your moderator for this session. It's our second session in the East African Journal of Neurological Sciences, and you're welcome to this bootcamp as well. So, I'll be representing XYZ Research View. The East African Journal of Neurological Sciences Journal Club is a collaborative initiative by organizations, and these organizations are the East African Journal of Neuroscience, together with Journal of Kenyan Association of Physicians, Journal of Obstetrics and Gynecology of Eastern and Central Africa, the Annals of African Surgery, and Anatomy Journal of Africa. So these organizations are partnership with XYZ Medicine, SCORI, which is Standing Committee of Research Education, University of Nairobi Research Club, Kenyatta University Medical Research Club, and the Student Surgical Forum. So our goal for this bootcamp is to promote scientific critical appraisal skills, to enhance readership of local journals, and to spark greater interest in publishing and peer review among early career researchers and medical students. And to highlight is that this platform has been provided to us by Daktari online healthcare professionals to access continuous professional development, education, connect, and collaboration. It's one of the Africa's leading online medical resource center. So for today's session, it will run for 1 hour and it will be structured as follows. So the first 15 to 20 minutes will have a presentation by one of our partnering organizations, that is SCORI, and this will be to summarize the selected paper. And the next 20 minutes will be an open discussion, and this will be for appraisal by the audience. And finally, we'll have closing remarks and insights from our guest editor, Dr. Ben Mutiso. So please feel free to share your thoughts, questions, and critiques in a respectful and engaging manner. And this is a safe learning space for all levels of experience. So with that, it's my pleasure to invite Ms. Priscilla Lilechi to take us through today's paper, which is titled The Effect of Cerebrospinal Fluids, Biochemical and Cellular Properties on Ventriculoperitoneal Shunt Survival. Welcome.
Hello, guys. Thank you for the warm welcome. I'll just speak briefly of the Standing Committee of Research, which I am representing. I'm the research coordinator of Kiambu Universities or Kiambu region. We have ongoing research ongoing in all the various regions with their coordinators. So I'm here representing the Standing Committee of Research in Sake. And I would like to just give you guys a brief overview of what we do so that if you're interested in joining us, feel free and feel open to join us from wherever you are. We've been doing some workshops in this September to December academic year. We've done data analysis training workshops. We've done systematic review trainings. We've also had some fun days and research skill webinars. We have some oncoming activities, and some of them are the grant writing workshop. We also have a scientific conference coming up and a scholarly exchange program for those people who want to, go abroad and see how research is done in other areas of the world. So feel free to plug into our social pages to be updated of the various activities that we have. Our social media pages are all titled SCORI, or you can find them under Msake's website on Google. Yeah, so I think that's it. I'm going to start. I hope you guys can see my screen. And today we're going to go through the paper that we had been sent by our emails titled CSF Properties and VP Shunt Survival. Yeah, so just put this here. The paper was a cohort type of study. We all know that there are various types of studies and various ways that papers are collected for this. So for this specific paper, it was a cohort study, meaning that they were working with a group of people and following up through their progress, and also using a certain criteria to identify their cohort. Yeah. And so the major thing that was going on in this paper was just them examining how the CSF biochemistry and cellularity impact shunt outcomes. So I believe we are all health science students, and we know things to do with hydrocephalus and how shunts are the major type of treatment used to reduce the levels of CSF. Then ventricular peritoneal shunt is the major type of shunt used apart from others. We have the ventricular, there's one going to the heart, ventricular atrial, if I'm not wrong, but this one is the major one. So I tried showing an image of how it looks like from here, and that is basically how a ventricular peritoneal shunt looks like. Just trying to drain the excess CSF from the ventricles right down to the peritoneal cavity. So from the introduction of the paper, they were trying to explain to us the problem statement, or rather the burden area in East Africa and Kenya as the representative area of study at large. And hydrocephalus was greatly explained, the rates that have gone through in Nairobi, Kenya, and also the burden that has been there. Yeah, so they started by talking about a regional burden, then they got it down to Kenya. Yeah, so you can see that East Africa had a rate of about 0.47 to 0.60% of 100 live births. And when you narrow it down to Kenya, about 4,900 to 8,200 cases annually, which is quite a significant number, let me put it that way. Yeah, so it actually shows the importance of doing this research, and that it is affecting a lot of people. It's going to have a lot of impact in when the results will be out to influence the policies, or rather how the health system goes on. They also talked about the treatment reality, highlighting that the ventricular peritoneal method is the main shunt method used for treatment of hydrocephalus. But they also let us know that 30 to 40% of those shunts fail within the first year. That's also another reality or burden they have been able to highlight to us in the introduction. So we move on to the study, or rather how the paper was done. So from what I could be able to capture from the cohort study that has been published, is that they worked with 82 patients which were enrolled. So the area of study was Kenyatta National Hospital, and then they worked with 82 patients, and they were looking at various criteria. They had an inclusion criteria that they were looking at, and I was able to capture the exclusion. I couldn't really get the inclusion criteria quite well in the paper because it was scattered, but I was able to note that they had highlighted that they were excluding all the mechanical failures that were attributed to the shunt failure. So they're only dealing with biochemical, factors. And they had 82 patients enrolled for the surgery. Enrolled. They were looking at patients who have had hydrocephalus and have been enrolled for VP shunt surgery, and then they followed them up for 3 months to be able to assess shunt failure or shunt functionality. Yeah. Then number 2, the baseline assessment that they were using was the biochemical factors that each patient did when they were going for surgery. So they pointed out that in Kenyatta National Hospital, every patient who's going on for shunt surgery is tested and assessed for protein levels, glucose levels, and cell count. And those are the records that they were using to, note down the key areas of each of these patients, which is quite something I liked about the paper, because they were not going on to start the assessment again. They're just using the records that are already in the hospital. And they classified the the group of patients into normal versus abnormal CSF biochemistry patients. So they looked at the protein, glucose, and cellularity groups, and they were able to divide it into normal and abnormal. And apart from that, just to repeat again, I had said they were following up the patients for a period of 3 months. And maybe just food for thought as we continue with this session, maybe you could be thinking, is 3 months a good timing for follow-up for this shunt functionality or surgeries, according to your opinions or according to what you think? Yeah. So the demographics of most of the patients that they were dealing with. So we already talked about the total of patients, 82, which is quite a good number. But it's also open to think through if you feel like the number was too little enough, or rather what the number they were considering to work with, it was enough to be able to validate this research paper. The number of male patients was the highest. The male patients were the highest. There's also a place they had highlighted that male patients, the disease was predominant in male patients. So this was actually confirming the statement they had made, I think, in their discussion. So 56% male. So there are 46 male patients and 36 female patients, but it's not quite, a large or significant difference, but it's something we can note about that. Then the mean age was 15.5 months. So we are talking about 1.5 years, 1.5 years, 3 weeks to, the mean age is around 1.5 years. And most of the patients were 3 weeks to 10 years. That was also strengthening some points they had made in their discussions or rather introduction about hydrocephalus being a major congenital disease in most babies patients. So it's a pediatric issue. So we can see that most of about 78% of the patients were under 1 year. So that is quite significant. 78%, that's a lot. Yeah. It's reflecting the predominant nature of hydrocephalus in this population in East Africa and in Kenya at large. Yeah. So just to highlight some causes they had talked about, because a lot was talked about the causes of hydrocephalus when they were enrolling for patients in the discussions and also in the introduction, is that about 82.9% of the cases were congenital, which is quite significant, and the acquired cases were only 17.1% of the cases. Yeah, and then for the congenital cases, that 6% of the congenital cases were due to Dandy-Walker. Dandy-Walker is a disease where the vermis that has not, the cerebellar vermis has not developed well, and so the ventricles tend to enlarge and cause an accumulation or an increase of CSF. So 36.76% of congenital cases were due to Dandy-Walker malformations. And also they had talked quite significantly about spina bifida and it being in about 21.9% of the congenital cases again. And we all know spina bifida is a neural tube defect, so it was quite something to note, which was nice that they pointed that out in their paper. Yeah. Oh, and also one thing to note is that these courses were also consistent with the patterns that were reviewed from other research papers. If you look at the discussion section of the paper, which was also quite good to notice. So, So in the assessment that they did, remember when we were talking about the study design, we said that the baseline assessment that they were using was the CSF biochemistry levels and cellularity. Yeah. So they looked at the CSF protein levels, CSF glucose levels, and the CSF cell count, and they had quite a number of results that they spoke about in the result and discussion section. So under protein levels, they said 52 of the 82 patients enrolled, only 52% had normal levels, and which is on the higher side, and then 47.6% showed elevated proteins with that range. So that is around with a mean of 588.3. So if you look at 52 against 40 something, again, the CSF protein levels were significantly high. And then for glucose levels, which was even quite more significant, the 65.9% of the enrolled patients had reduced glucose. Yeah, and we all know that increased glucose levels are a great risk factor for infection, inflammation. Apologies for the repetition there. And then the CSF cell count, almost 86% had normal count. So from this baseline assessment, I think they ruled out CSF cell count as a major factor for assessment in cases leading to shunt failure, because they saw that almost all or most of the patients had normal counts, 86%, which is quite high, a high significant percentage. So they ruled that out as a factor affecting shunt failure, and we remained with CSF protein level and CSF glucose levels. Yeah, so one thing to note from the results, hoping you guys also noted that, is that this reduced glucose, 65% had reduced glucose levels. There were reduced glucose levels in both patients who had shunt failure within the 3 months, and patients who did not get shunt failure, or patients who had successful shunt surgeries. But for CSF protein levels, most of it was high in only the patients who had shunt failure. Yeah. So from the finding, they let us know that elevated CSF protein concentration was the highest likelihood. It was giving a risk of about 8.7 times failure of the shunts. So again, as I had said, almost all the patients who had, I don't think it's almost, I think all the patients who had shunt failure had elevated CSF protein level. But for CSF glucose levels, some had reduced glucose levels, but they didn't have shunt failures. Some did have reduced glucose levels and they had shunt failures, so it was 50-50. But for CSF proteins, it was very high, especially in patients with shunt failure. So CSF protein levels became the most predominant factor, or the most predominant risk of shunt failure. So they also talked about the progress of the patients quite well. So 20% of the patients experienced shunt failure at 3 months, and all of them had elevated protein, and only 2%, only 2% experienced shunt failure at 3. Oh yeah, so the patients who had normal protein levels, only 2%. Yeah, you see the difference? Only 2% experienced shunt failure, but those with elevated protein levels. But most people with elevated protein levels, 20%. So we're looking at 20% against 2.3%. The people with shunt failures, only 2% had normal protein, but all the rest had elevated protein, just to simplify it. Yeah. And then the average time of failure, according to the progress time they gave us. So 1 month as 30 days, so 60 days was around 2 months post-insertion. Most patients had failure at around 2 months post-insertion in the affected patients. So as we continue, I want you guys to note that we are talking about infants, so look at that. And also, we are talking about biochemistry, lab, and surgeries. Yeah. I hope those points will help you think through as we are going to reach the critical appraisal part. So the shunt outcomes from the patients who are enrolled, you can see the failed percentage versus the functioning percentage. So you can see that quite a number of the people who had enrolled had functioning shunts and a little bit of people had failed shunts. But the number of people with failed shunts was also quite significant, even as much as they were at a lower level than those with functioning shunts. And they also noted that during the check of progress of the patients, there were no infections observed during the follow-up period. So this was entirely due to biochemistry factors. Also remember we had excluded mechanical factors, so this is also just entirely due to biochemistry factors. And as we said, the key factors of failure are these three that I've listed each down. So elevated CSF proteins being the most predominant factor, followed by reduced CSF glucose, and CSF cellularity having no correlation because we had said earlier that 86% of the patients had normal CSF cellularity, so it was somehow sidelined as they were looking at the factors of failure. The predictors, yeah, the predictors of failure. So you can see the P level. They used the Fisher's test for data analysis, where we use the P level number to test for hypothetical statements that you make during a research paper. So if the standard P value was, for example, I think for this paper, the standard P value was 0.047. So we usually use the standard P value to check if whatever we are testing is significant, if the hypothesis is a yes or no. So most of the time, if it's below standard, it's a no, and if it's above standard, is a yes. Most of the time, yeah. So the clinical implications. So this was under discussion. After they talked about the results of the paper, they gave us some points of what they think the clinics need to change concerning hydrocephalus and shunts. So screening priorities, talking about how most pediatric patients had elevated CSF proteins, and it is essential for them to have routine biochemical assessments every now and then, especially when nearing the surgeries. And also, if they know that a patient had elevated proteins, they should ensure that they follow up and they detect any early signs of blockage before it gets worse, because it gets so frustrating when the shunts block completely and they have to go through the surgeries again. And also they emphasized on more studies needed to inform better device design, because probably the interaction between the proteins and glucose with the device material was a major factor causing shunt blockage. So more research is needed to inform better device design of these shunt tubes. Because you guys, if you remember, they're like tubes running through your ventricles to the peritoneum, as you can see in this diagram. So the device design needs to be evaluated more. So in conclusion, from what I concluded from the whole paper, I concluded this into just 4 things. Shunt blockage still remains the primary challenge of these patients. Elevated CSF proteins and reduced glucose was significant in predicting early shunt failure. And then number 3, it's important that we implement risk stratified follow-up protocols. The medical doctors, the most medical students, to improve early detection of complications. And then they also gave us some research directions that if you're thinking of doing more research on this, look at the shunt material and modifications. And also they recommended longer follow-up studies. Remember that the follow-up was 3 months. So they recommended longer follow-up studies to be able to look more on the risks of shunt blockage. Yeah, some good things they highlighted about the paper was that this study is the first paper describing CSF biochemical parameters in East African children with hydrocephalus. And I believe there's ethical approval, though I didn't clearly see it in the paper, but I'm assuming there was. Yeah, I think that's the end of this paper. And we'll probably ask more questions as we continue. Thank you.
Thank you so much, Priscilla, for that clear and insightful presentation. I believe we have all gained insights from it. So we'll now open the floor for discussion, where we'll invite Mr. Felix Njoroge to take us through. So feel free to ask questions, to share your thoughts or comments on the different sections of the paper. So you're welcome to lift your hand or use the chat box. So welcome, Felix.
Thank you, Teresa. Thank you, Priscilla, for the um, presentation, and we also congratulate the authors who conducted the research. So for this next part of the session, I will just be also co-assisting Teresa to moderate. And so how we'll do it, we'll go through the paper section by section. I'll project the actual paper.
Yes,
It
we
is,
can.
okay, great. So we'll start, and we'll somewhat make reference to the appraisal document that we had shared via emails. It's just to help assess various parts of the paper. So we'll start with the title and authorship, which, as you can see, was the effect of cerebrospinal fluid, chemical and cellular properties on ventriculoperitoneal shunt survival. And the authors are listed there. So we welcome any feedback. Remember we talked in the materials we shared, the title must specify the population, the exposure and outcome because it's a cohort study, and the design as well, and the type. So we welcome anyone to just unmute or share your feedback on what you think of the title, whether it's very good or whether there are areas we can improve. Keeping it respectful, of course, don't bash the editors or the authors. So, okay, I can actually see the chat box, so I can just read. So, Vincent points out that it indicates the exposure and the outcome. So, the exposure being the CSF biochemical and cellular properties, and the outcome being ventriculoperitoneal shunt survival. However, the title does not state the population, and as was brought out by Lilechi, I think it was largely a, a pediatric population, and states the type of design for this study. I think everyone else has said pretty much the same thing. So perhaps someone can unmute, just lift their hand up to contribute and maybe give another draft or an idea of what the title would sound like if it incorporated all these other things, not to improve it and make it better.
Hello.
Hello?
Hi everyone. My name is Mao. Okay, regarding the title, I found that it just missed some key elements. I feel like it didn't mention the population or the study design, and it, it wasn't very. I and I feel like the biomedical, it didn't actually specify the type of the extent of the effect. And regarding the authorship, I see that the section, it didn't indicate the substantial contribution of the authors and or their credentials.
Okay, maybe Mab, before you go, could you give us an example of how this title would look if we worded it differently?
I think if it was the effect of the supraspinal fluid, it's first say it's a prospective cohort study, and mention that it have been done in Kenya. I feel that that adjustment will make it more better for so when people will go and search or wanna read about this article, will find it and will be describing the content of the study.
Okay, yeah, thanks for that. I think that's so maybe, and maybe just before I get to rewarding the title, what do you guys think of the use of the word effect? Maybe as opposed to something like association in the title. Anyone with thoughts on? You can also write it down. Uh, Maybe Clarence, you could expound a bit more on why Sulubi would like to be unmuted. Maybe Sulubi, you could lift your hand up and then
Yeah, hi.
you'll be unmuted.
My name is Nsalubi. So I think effect can be a bit misleading because it's not a given that, let's say, elevated cerebrospinal fluid proteins will lead to shunt failure. So yeah.
Yeah, I think I also agree. Because cause and effect it's quite difficult to prove in research, and it needs more stringent study design methods like randomized control trials. So where you really control everything and you expose the different groups to different things, and it's experimental in nature, and by design um, cohort study such as this one is not experimental, where you're exposing where you're giving one intervention and the opposite another intervention to a different group. So I think maybe as was also implied by the people in the chat box, I think association, correlation maybe would be a better word. So yeah, I think that's. Does anyone have anything to add to the title before we move on to the abstract? So maybe it will be the association of cerebrospinal fluids, biochemical and cellular properties on ventricular peritoneal shunt survival in a pediatric Kenyan population, a prospective cohort study. So I think that will be a better worded title. And I think in terms of the authorship, for the other details that maybe some papers have, others don't. I think this is more on the editorial side. These are just the details that are taken by our journal. So, but maybe in the future we'll try and have more details on author contributions in the authorship points. So we'll move on to the abstract. So we won't go through it. We'll just ask if anyone has feedback from what you read. So you're asking yourself the questions: is the design, time frame, and statistical methods clearly reported? And do you think the abstract here that's been presented summarizes all the major study components accurately? Anyone with input? You can use the chat box. Someone says they can't hear me. I hope I'm audible. Maybe we can get someone who'd unmute. That would be great.
Yes,
Just one person.
Um,
Okay. Clear?
okay, I think the design is also it's indicated properly within the abstract. The time frame, they said it's 3 months, so it's already indicated. The statistical metrics, they give the risk, which is 8.7 times. And also in terms of the demographic features, it's also indicated, but there is no risk ratios, hazard ratios, and confidence intervals that are given. Yeah. And does the abstract summarize all major study components accurately? I believe so, yeah.
Okay. Yeah. Thanks. Thanks for that, Claire. I think we'll probably come back to some of the discussion points in the materials and methods section, and maybe discuss a bit more on some of those aspects. But yes, I think that's okay, unless anyone has something that hasn't been mentioned. But we'll move on to the introduction. But if you feel like there's something you've mentioned that hasn't been brought out, and maybe Teresa, you can help check the chat box. If there's something that has not been mentioned, we can go back to it. But I think we'll go to the introduction. So the introduction, the expectations of an introduction is that it's supposed to summarize the current knowledge on this topic, the research gap, and the rationale for using a cohort design, as well as just mentioning briefly on the exposures and outcomes and the hypothesis for the study, while also citing different literature. So someone you can comment on whether this is satisfied according to you and what you found out as you reviewed the paper. Maybe Teresa, you could help out with the chat box.
I was going to say that I think that the rationale for this study is justified because, as the introduction states, this region has one of the highest rates of the shunt blockage, and also the reasons for that haven't been determined. So it's very important for the research to be done. But I noted that the hypothesis, they didn't state a hypothesis in the introduction. So one of the points in the questions was, is the hypothesis precise? So it's hard to judge if the precision because they never stated a hypothesis, but they did state the aim. And yeah, so that's what I have.
Maybe just a follow-up question. What do you think will be a good hypothesis for this study?
Oh my goodness, I don't think I can think one up just on the spot. I apologize.
Oh, it's okay. It's okay. Not sorry for putting you on the spot, but if anyone would also like to just chip in.
I think it would be to establish whether there's actually an association between the shunt failure and CSF protein / glucose.
Yeah, I think that's okay, and I think it was somewhat mentioned. Yes, I think it was somewhat mentioned at the end. So by mentioning the research question, I think the hypothesis is included. You don't have to mention the null and alternative hypothesis, but I think it's mentioned at the end. Then I've seen a few questions on. I don't. So from Julie, I don't think they justified why they used a cohort study and not any other type of study. Okay, I think anyone with thoughts on that? But maybe from just my thoughts, I think as long as the study fits and they've described why they are doing it, because it's a study where they are following people for some time. That time duration is what, and it's also observational. So it means you don't take experimental, so it can't be any experimental design. You're following people for a duration of time, so it can't be a cross-sectional study. So that I think maybe it's not very necessary. I know it's in the template to justify exactly why you specify that design, but as long as the rationale for the study comes out well, I think that should be okay. But we also welcome more questions on that. So anyone else with more thoughts on the introduction?
Sorry to take you back, but the abstract part.
Yes.
Yeah, so in the abstract, I also noticed that they didn't mention the effects that when you go further in the paper, you'll find that they were writing, like, for example, how the outcome was measured clinically. They talk about things like nausea, headaches, all of those things. But in the abstract, none of that was mentioned. So there's also that. And then also, if you look at the format of the abstract, all the qualities of the abstract, like background, objective methods, all of those are like highlighted, or rather they're in bold, but then the conclusion isn't in bold. And I guess that is like a formatting error, but I also noted that, yeah.
Yes, that's most definitely a formatting error from the editorials, just the copy editing. But yes, that's a very good catch. The conclusion should be in bold, just to make it appear clearly. And for the initial point, I think they ought to have hinted just briefly, because the abstract is going to be concise, just a maximum of about 250 to maybe max 300 words. And so you can't include everything, but they hinted briefly at the selection criteria. But yes, thank you for that. So next, I think there isn't
In the
more. You can just
introduction,
yes.
when you're talking about the hypothesis, is it given in more of a statement format or like as a question when you're trying to establish a hypothesis?
I think other people can also give their feedback, but from what we've seen from a number of other papers, as long as you state the objective quite clearly, it somewhat also covers the research question and the hypothesis. So if you say the aim of this study is to do this, it's or just to investigate whether this does this to this particular thing does an effect on a particular outcome, that usually encompasses the hypothesis, but I also would welcome any additional input from anyone and also from the rest of the editorial team, from the other journals, and also EAJNS, anyone with additional thoughts is very welcome. Okay, yeah, when we still debate that, I think we can move to the materials and methods. But if you have an additional point that comes up, feel free to come back to this point. So materials and methods, I think here we'd want to spend a bit more time, since for the methodology, it tends to form it's the whole study. That's what the study is all about. And it's the most important part of a paper, even when you're appraising and evaluating whether it's good or not, and whether it fits the research question. So we'll go through step by step, because methodology should have different key components, and we'll see whether they've been included, and whether if they've been included, they've been included well. Yes, yes.
Sorry for interrupting. On the part of hypothesis, I was wondering, because one of the hypotheses that has been stated earlier about the association between the biochemical aspects on the shunt failure. So if we have just that one hypothesis, how does it now reflect if now our finding, the biochemical factors are like three? For example, we have the protein issue, we have the glucose issue, and we have the cellular issue. And you find now the cells or the cellular issue is not associated. Then you find that there's an association with the protein and glucose, but there's no association with the cellular aspect. So if you had stated just one single hypothesis, and you're not broken it down into maybe three different hypotheses, so how do you get to a conclusion yet one of the cellular aspects is associated and the others are not? So maybe guide on that.
I think for that, because this one is more of a broad objective. Maybe they should have broken it down more into specific, because I think there's specific properties, biochemical and maybe protein, glucose, and all those ones are covered by this blanket term. So yeah, maybe they ought to have specified that they were evaluating each of the parameters independently. So yes, I think that's okay, but I also welcome additional thoughts on the same. So for materials and methods, so number one, I would want we can comment on the study design and setting. So has the study design been mentioned? And that, because it's a prospective, I mean, a cohort study, is it prospective or retrospective? Have they identified the setting adequately, the duration and source population? And have they also mentioned ethical approval? and various considerations for such a study. So we'll start with that. We welcome people to unmute.
So for myself, what I saw from the paper, the study with regards to the study setting, I think that was stated. I think they said Kenyatta. So according to me, I think that was clearly stated, as well as the description of the study design and how they will have the different arms and all that. The part that I felt maybe in the participation, the participants and the selection, in the exclusion, I was trying to think. So what if somebody, for a patient who is already on some medication such as antibiotic, maybe during this period, are they still going to be included? Since maybe the use of the antibiotic might have an effect on maybe those biochemical aspects, and whether it will have an effect as finally on the shunt failure or survival. So maybe that is an aspect I felt maybe needed to be included in the exclusion so that it is clear.
Yeah, I think we'll definitely come to that. That's a very good point, because it's one of those points that has to be very, very clearly brought out as you discuss confounding and bias control in your patient selection. And I think we'll come to that. And we'll discuss it more. I think you'll also maybe come back again and share a few other confounders you may have identified from your study. But I think on study design and setting, I think the only thing that was not clearly stated here, ethical approval. So maybe whether from KNH or N, and also matters to do with consent for the study. As someone had also mentioned prior, because it was a pediatric population, every population needs consent, but even especially in pediatric populations, it needs to be also clearly stated that consent was, the ethical approval was gotten, and in some settings, also prospective cohort studies need to be registered. There are some registries for such, but not in our setting. But yes, mainly the consent aspect and ethical approval. So the next part, which is selection and the criteria. Yes, go ahead.
Felix, I also noticed that still under ethical approval, I didn't see them mentioning what will be done to patients who have experienced VP failure and the post-study follow-up for such cases.
Okay, yeah, I think that's a very good point. And I think maybe for our learning, I think the best way for doing the methodology will be to have subsections to ensure that all these things are covered. Like one subsection where you just talk about study design and setting, participant recruitment criteria, exposure measurement, outcome measurement, follow-up and attrition, confounding, statistical analysis, and all these things that should fall under the methodology. So rather than having it as continuous prose or paragraph where things are combined, separating them into subsections really helps to make sure it's comprehensive. But yes, that's also an important part. So maybe the next part on selection criteria, anyone with feedback on what you thought about the recruitment process and how the exposed and unexposed groups compared to each other, and yeah, and so whether the selection criteria, inclusion, exclusion were clear and also justified. So again, feel free to use the chat box.
Okay, so for the selection criteria, the inclusion criteria, well, it wasn't like explicitly stated. It seemed like it was implied. So in the article, it says patients undergoing VP shunts for hydrocephalus, and it excludes again mechanical failures. It doesn't define like age ranges or if there was infection status was included in the inclusion criteria. So there was no like clear eligibility criteria. And then also the sampling method. They do not like explain how they were sampling. Was it consecutive or was it convenience sampling?
Yeah, thank you for that, Eunice. Those are very well brought out points. I think that were not well captured, and I think it will really help if there were specific sections that brought out all of these points clearly. Thanks for that. Anyone with additional thoughts in addition to Eunice?
I had an additional thought, Clarence. I guess this will be ahead of it, but the confounders they were only stated like age and gender. I don't know if that's out of the point that you're on, but they only stated there was no attempt to control for such confounding like age and gender. So I thought that was a big issue, especially when it came to interpreting the results.
Yeah, that's true. Confounders, and we'll come to those, and we'll actually spend a bit of time listing them, trying to think of some others that may not even have been listed for this study, because they really affect the validity of the study and how you can interpret the result for any study, I believe, but especially for cohort studies. So I think the learning point from this will be that it's very important to have like a clear and a very robust inclusion and exclusion criteria. It shouldn't be implied, it should be well, so that for also the study should also be possible to be replicated elsewhere, and the selection criteria is really important. And so maybe it's mentioned, but maybe more detail will really help in that aspect. So in terms of exposure measurement, we can also have a few remarks on that. So
before we continue, could I comment on study setting and design?
Yes.
So there was like the study period was not well defined. Like we don't know when the study was conducted. Yes, the paper maybe it was released in 2022, but we don't know when they conducted the study. Was it 2021 to 2022? Was it during COVID? And then what else? Yeah, okay. That for now, that's what I noted.
Thanks for that. That's a very good point. Yes, it should always be very clear, be as detailed as possible. The 3 months should be this month to this month of this particular year. Yeah, so thanks for that. Any more additions?
Yeah, just a point on the exposure. So they didn't state exposure status, how it could change during the follow-up period, and how such a change could be managed. So if the patient's condition got better or worse, if they got an infection, like how would they control for that?
Okay, yeah, thank you for that. Wallace?
Yes, I think in that last statement where your cursor is at, that statement, I feel it should have been more details should have been added to it, because what are these baseline CSF biochemical and cellular properties which you used, and what is the criteria? Because what if one has normal number of cells, but the protein levels are abnormal? Will that be normal, or will it be stated to be abnormal? So did you use all the three parameters to say it's normal, or did you use one or two or three parameters to say it's abnormal? So I think that should have come out. Which of these parameters did you use? Just the cell number, the protein levels, and the glucose levels? Did you just use that to say it's normal or abnormal? I think that did not come out.
Thanks, Wallace, and I completely agree. Especially exposure measurement, because that's the main thing. Because in cohort studies, you're classifying your participants based on exposure status, exposed versus non-exposed. So it needs to be very, very, very clear exactly what this exposure was. And you should go, for this case, it was the CSF biochemistry and cellular properties. So it needs to be clear what normal meant and what abnormal meant, because those are the two categories that are defining the two groups being followed. So that's very true. And maybe someone now can also comment on outcome measurement. The outcome was this shunt function and the outcome of the shunt. So maybe you can comment on what on how the description for the outcome in terms of what shunt failure was, maybe the clinical signs, imaging signs, and whether this detail was satisfactory for you. Again, unmute if you're able to. I think if you unmute, your points are better put across.
I would like to comment on that.
Yes.
So I noticed that only the patients with signs of shunt failure underwent the CT scan. And so I wonder if that brings about like verification bias, because if you know that the patient has the signs of shunt failure, with that knowledge, you might come to a conclusion which, while you're judging the CT scan. And it's possible that some patients were maybe asymptomatic for the shunt failure or experiencing mild shunt obstruction, but they won't go for the CT scan at all.
Thank you, Nsulubi. That's a very good point in terms of outcome measurement and assessment. Any additions?
Could I comment?
Yes, Lynn.
I thought that they missed on reporting the timing and frequency of assessments. I think that should have been important. It was important and it should have been mentioned. And also, they did not use the same methods for all the group, because it seems that there are some patients who had MRIs while others had CT scans.
Okay, yeah, I think I had missed that point about MRIs. Okay, I didn't see that, but yeah, that's true. If you use different parameters to assess the groups, it means that maybe it affects that comparability, because the tools that have been used to measure the both groups are different, so it may affect the assessment. So those are very important points to pick up and also maybe learn from. I think even as we design our own studies for the future. So I think that's good enough for the outcome measurement. Maybe someone can now comment on follow-up and attrition. So maybe now you can comment on the follow-up duration, its completeness, and the loss to follow up, because often not every person who's enrolled at the beginning goes up until the end, and and whether this was brought out well and also handled appropriately.
So for the follow-up period, they said 3 months. Yes, the author at the end states that it was short, which is true, because for VP shunt failure, they usually fail at 6 months to 12 months or more. So 6 months would only detect early shunt failures. And then for completeness and censoring, those were not, what do you call it? They were not like fully described. So we don't know how many of the patients that were enrolled finished follow-up. And if they were lost to follow-up, we don't know what they did to correct or manage for the missing data.
Thank you for that, Eunice. That's a very good point that you've picked up. Yes, thank you for that. Any additions?
I think what would have really supported the paper, although this might just be my own opinion, is individual patient data. Because even what the guy before me said, like everything is mentioned about, like, for example, individual patient follow-up, or even for us to be able to measure, like, what level of CSF protein increase are we actually calling an increase? It can increase by 0.00 something, and that might not be like a relevant increase. Like, maybe they could have given like a standard value of which all of the 82 patients, their protein increased by this amount or by that amount, so that if somebody actually wants to replicate this study, they can actually use that. And none of that was mentioned. Like, it was just said increased or this decreased, but like, what exactly is this value of increase?
Okay, I think that also goes to the outcome measurement and the parameters and how you define the outcome from your exposure. So yes, thank you for that, Arnold. So I think we can now go to confounding and bias control. We can have comments on this. A confounder, just by definition, is it's any other variable or any other thing that is associated with either the exposure or the outcome in a study that can distort the true relationship between the two things you are assessing. So it's basically what else could explain the findings besides what has been mentioned, and they can, mostly these external factors that always have to be put into consideration. So maybe we can at this point list some of the confounders you picked out from this study that may have explained, that may contribute to the outcome, that maybe were mentioned or were not mentioned.
I identified age as a major confounder because there's a major imbalance in the ages of the patients. They range from 3 weeks to 10 years. And in the analysis of the data, a significant difference of a p-value of 0.047 was found. And so, yeah, as I said before, it identified age as a significant factor for shunt failure, as a major confounder. But the study fails to report using any, I think, Cox regression models to separate the effect of age from the effect of abnormal protein levels.
Thanks. Thank you for that, Tsulubi. Any other confounder that was identified besides age?
So, can I say in the methodology section of the paper, there were no specified list of confounders.
Yes.
But in the report section, they do report on some confounders. Age was already said, etiology of the shunt failure, the surgeon's experience, and infection status. I think they should have been clearly stated in the method section, and also they should have reported for adjustment strategies.
Thank you for that. That's an excellent pick out, Eunice. I think you did a very good job assessing the paper. There are quite a number of confounders that ought to have been mentioned and brought out clearly, and for such, in the methodology, it needs to be listed. All this because not all these patients had the same cause of hydrocephalus, and so different causes may have different outcomes in terms of how well they respond to treatment. That may be another confounder in that it can lead to a difference in the outcome besides the difference in CSF parameters. Age, you've seen, it's quite varied. The surgeon's experience, I think it was mentioned somewhere that the people operating were different. Some were residents, others were senior consultants. You see, will that lead to a difference in the outcome of the shunt? And all these confounders ought to be mentioned, number one. And of course, now to mitigate the effect, to do what is known as bias control, and that can be controlled either in how you in the design of the study. So as you even before you implement how you're going to match, there's something called matching the two. So meaning you're only comparing this patient who had normal CSF and was operated on by a consultant to another patient who had abnormal CSF and was operated on by, a consultant, and all those things, or to go further and in the analysis, implement some methods. I think Nsulubi has implied some of them, and I think we'll now get to that. On statistical analysis, so we can comment on statistical analysis. As for the statistical analysis, has it been well described? Has the software that's been used been well brought out? Have the appropriate tools or statistical tests that can be used to assess such associations been mentioned and well brought out? Maybe we can comment on that.
I see from the paper that the statistical analysis wasn't stated. They didn't say what software program they used or what are the parameters and how they should handle. They did handle the data and all of that. I feel that it must be more clear and precise, and just to be more transparent. So to let people know how they did demonstrate the data and how they analyze it, so we can so that should support the conclusion.
Yes, I think that's very true, very important that the statistical analysis is described in detail. And maybe perhaps may pose a question that maybe you can answer. So what statistical tests do you think will be useful and appropriate for this study to assess the association, to assess survival? Maybe you can either use a chat box or also just unmute and answer. I think unmuting will be so much easier.
No.
Oh, yes, Dr. Mutiso.
Oh, oh my goodness. Hello, can you hear me?
Yes, we can hear you.
Oh, yeah, sorry. I think I missed. I just missed the last part that you were talking about. What did you ask again?
Also, the question was which statistical tests will be useful for a cohort study. I think it was more of just a general question.
Oh, sorry. I think I may have unmuted myself. And not. I've really just been sitting in the background and following, since I'm the author, so I may have a little bit of conflict, but I'm learning a lot from the comments. So I think I'll just continue to sit in the background and listen in for now. Maybe I'll give my comments at the end. Thanks.
Yes. Thank you, Dr. Mutiso, for also agreeing to join. I think maybe not many authors would agree to sit and listen to their paper, but I think it was yes, thank you for joining. He's an associate editor at the East African Journal of Neurological Sciences. This was one of his projects as a resident. Again, as you realize, or if you've ever tried to do a project, it's quite difficult to do a perfect project. We thank Dr. Mutiso as an author and also for joining us today. So maybe back to the question. Yes, I see there are a few answers. Regent says use of multivariate analysis to adjust for potential confounders. Yes. Binary logistic regression. Yes, because you're using the exposure as a predictor of the outcome. So logistic regression for association, maybe could do chi-square or but I think it was mentioned somewhere that they used the Fisher's exact test, I think here, which is an an alternative for 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 the chi-square test. But I think we can just go read more on maybe some of the others. Things like maybe we can just write it down and maybe we'll add it to the email of additional resources to review, because we're only reviewing one type of study design once throughout the entire cycle of the bootcamp. So maybe go read up more on all the different statistical tests that are appropriate for cohort studies, Cox regression models, logistic regression, and there's something known as Kaplan-Meier curves for survival, which also add a lot of value in terms of the information that is provided as a result, as part of the results from a study. Maybe among others, I think you can also just read more, but we'll probably send a more detailed email as additional reading material for those who'd like to maybe read more on the statistical aspect. But yes, and even as you're implementing the study, I think it's also useful sometimes to also consult a statistician. I think they really help to ensure that even the statistical aspect, which can be a bit challenging, is also well tackled. So we'll move on to the results, and so we'll go over this section a bit faster. We spent more time in the methodology because it's the most important part of our study, and it's what maybe determines everything about the study in terms of its utility and in terms of its validity. And also, how well you can interpret the results, because often people will tend to be a bit exaggerate a bit in terms of their discussion and the interpretation of the results. So you always have to check whether the methodology matches the results provided. So I think for this, we can just comment generally on the appraisal of the results. So have the outcomes been reported well and are represented appropriately in terms of the demographic characteristics, and also all this and the comparability of the two groups, and so also whether the risk ratios, the p-values, confidence intervals have been given, and just basically everything that you managed to go through this. So this one, you can just let us know from what you interpreted from the results section. Were there any things that you picked out that maybe were a bit anything? And of course, appraisal is not just negative, also or critical. It was explained in the orientation session. Commenting what was done well is also a key part of the appraisal process. So yes, you're welcome to give feedback on the results.
I noticed that in the results section regarding the diagrams and tables, the table, the first table is show the one of the factors that associated with the shunt, which is one of the important parts of this study. But I believe that it should be one table that describing the baseline characteristic of participants. So it will be to summarize and show off the important parts. And I didn't see also there wasn't a diagram flow that listed to show the participants and recruitments and miss out participants of the study.
Yes, thank you for that, Mab. That's a very important point. So number one, to summarize, I think this also does that to some extent, but sometimes it's good to just have a table that summarizes all the demographic and important characteristics of both groups, and categorized by the exposure status, I think, rather than the outcome, because that's how you'd use so the demographic. So you said in the exposed group, these were So the exposed meaning these are the people with normal CSF parameters, and then next group the ones with abnormal CSF parameters. So these are males, females, and then just all these things about the demographics, even the age can be summarized and in sorry, using such a table. And yes, so that's a very good point you've picked out. Yes, and then for tables like this one, maybe it needs more detail, so that once you look at it in terms of the legend and the axis, so maybe the x-axis should be labeled down here. So age, and then in brackets, in months, because this was it in months? Yes, it was in months. It was in months, yeah. So that everyone just gets, and then percentage, it should also be more detailed. Percentage of patients or something. So that it has more information by looking at it from a snapshot. Anyone else with more feedback on the results?
I think
Can I
concerning the
comment?
tables,
Yeah, go ahead, Valerie.
concerning the tables, since the objectives we had were really general, we didn't break it down to proteins, glucose, and cellularity. I think there should have been like a good 2x2 table, because the way the table is now, we're not sure if the people who had low glucose also had high proteins, or the people who had high proteins were normal. So like that's how it's been divided. Like the 9 who have abnormal cellularity could be part of the 43 who are normal proteins. So it feels kind of jumbled.
Yes, I completely agree. I think it would benefit from splitting into different tables and then reorganizing such that even the thing that is used to categorize rather than the outcome should be the exposure. And yeah, and it will be easier to, because it may be a bit confusing when it's all combined like this. So that's true. Thank you, Valerie. Anyone else? I think there was someone else who was trying to give additional feedback.
I have a question.
Yes.
Is it absolutely necessary to have a participant flow diagram when you're writing the results section?
Okay, no, it's no, but it helps. It helps, especially if the duration was longer, and there was a lot of dropping out of participants. It helps to just yeah, it helps to just have a visual depiction of just how people were enrolled, how many people were enrolled into the different groups, exposed and unexposed. These were the people who, lost to follow up over time. Then these were the number of people at the end. Yeah, it just helps. So it's better to have it than not to have it.
Okay, I also have an observation.
Yes.
About the percentages. I think it will be more accurate if we maintain a consistent number of decimal points for each percentage that we present there, because there are the types of surgeries, if you follow through the calculations manually, you'll find some errors where at some point you have to truncate for the number of patients to fit in the percentages that have been put there. At some point you have to round off. So if the decimal points will be consistent, most preferably 2, it will be better.
Yes, thank you for that, Darwin. I think it's a very good pickup, and it's also maybe work that should be done on the for the editorial team, and also for the authors to be consistent across the decimal points and representation. And I think you see, like, this one also needs to have a number, because it should be the number n and then the percentage in brackets. So if it's not consistent throughout. Yeah, I think, but yes, it's a learning experience for everyone. I think this was the first issue ever for the journal, and these are processes that have been improved over time. And but yes, thank you for that. So any additional feedback on the results before we go on to the discussion and conclusion, and then we can close this section?
I comment on that. There's something I wanted to say earlier about the exposure and the outcomes. There was no mention of blind assessment. Like during the exposure, like the lab technicians, when they were measuring, was there some sort of blind, like was there some sort of blindness in that was not mentioned? And also the outcome, they can be an observer bias since they knew what they were exposed to, and also that can influence the outcome. And for the result section, there was no mention of in the outcome section, there was no mention of confidence of intervals or the relative risk or the hazard ratio were not mentioned.
Yes, thank you for that, Najma. That's very well picked out, especially even for the outcome measurements. I think as part of the assignment that we'll just share as just learning points from this session, we should all go and maybe read up more on, the statistical tests and the outcome measurements that are appropriate for cohort studies, and what information they provide, because some of it may be a bit complex statistics, but very important in reporting the results of a good, thorough cohort study. So thank you for that. And for the aspects on bias control, maybe yes, minimizing inter-observer bias and such is also very important to mention as part of controlling confounders in a study. So thanks. So I think there's no more additions on the results. Yeah, you can go ahead. Feel free to keep contributing, but I'm also checking the time.
I noticed something on table 1. Can you hear me?
Yes, you're audible.
I noticed something on table 1 when you're looking at the patients with spina bifida. When you add the total of the number of patients in spina bifida, the total comes to 80. Yet the number of patients involved in the study was 82. Yeah, so 57 plus 5 plus 62, 62 plus 3 is 65, 65 plus 15 is 80. Yet the total number of patients was 82. So, yeah.
Yeah, that's a good observation. That wasn't picked as well. So, yes. Thank you for that. And I think that's why the tables should be very easy to understand and well represented, because a lot of people, I think, also look at the tables to try and understand the results and maybe the various characteristics. So that's a very good pick out. Yes. So I think we'll move on to the discussion now. We'll keep it short. We'll just ask a few based on the expectations of discussion. So from what you reviewed, do you think the interpretation that was given in the result is grounded in data and literature? Have they addressed and explained their biases and limitations? And from the results, have they emphasized clinical and policy relevance of this study? And of course, interpretations are the interpretations of the results that they got from their study, not other studies. That should be the main focus of the discussion. So anyone with thoughts on this before we go to the last part?
Yeah, so for the interpretations are grounded in data and literature because they reference prior literature and that provides a biological basis for their findings. And regarding the biases and limitations, the article acknowledges explicitly the limitations of the short follow-up duration and the need for a larger patient group. But I think it fails to address the selection bias that's systematically created by the healthcare facility of preferring not to perform the VP shunt surgery on patients with elevated CSF proteins. And I also think that the clinical and policy relevance is emphasized very strongly throughout the discussion. And it also emphasizes the importance of further studies, and I think that's great.
Yes, thank you, Nsulubi. That's well summarized. Anyone else? Maybe we can take one or two more on the discussion. Let me check the chat box. Luyali says, yes, the discussion is well rooted in data. Is there a problem if literature is more than 10 years old at this point, or does that apply to references? So this is usually one of those debatable things, because maybe if you're citing a particular finding that was from a study that was originally done in 1990, it will be very unfair to ignore the original researcher and to go cite people who've cited that person instead. But the idea is that maybe for some of the practices that have been evolving, more literature that's come out more recently should be the one that's referenced. Or I've also seen, or maybe the 80 could be explained by the two patients who died. Oh yeah, that makes sense. Okay. Thank you, Clarabelle and Margaret. But that's usually debatable. Maybe different people have their thoughts, but not necessarily. As long as it's a relevant, valid citation, I think it should be okay. But the more current, I think, if a field has been evolving, more current practices should be cited. So yeah, I think that's okay for the discussion. I think Nsulubi has summarized the discussion well. Unless there is anyone else with an addition on the discussion, we can go to the conclusion. Okay, so conclusion. So is the conclusion consistent with the results and study limitations? And have they given recommendations based that are evidence-based and regionally relevant?
Indeed, the conclusions are consistent with the results of this study, and they have also mentioned the study limitations. The recommendations given were also good because they mentioned closer follow-up for patients that have elevated CSF proteins during just before shunt insertion, and also recommended further research so that they can see whether the chemical interactions between the proteins and the tubings could influence how the tubes are made to cater for the patients that have elevated proteins. Yeah, so I think it was well written.
Yes, thank you, Lynn. I think, and also on limitations, I think this has also been mentioned, and I think a number of the confounders were also mentioned in this part. So for the references, I think we won't really comment too much about that, but the expectations, we expect, sometimes around up to 20 something, depending on the type of paper. We have specific author guidelines, but they can go up to depending on the depth of the paper, and it should be reported using the Van style, which is a recommended style for the East African Journal of Neurological Sciences. Other journals may have different recommendations, but majority do recommend Vancouver. And and whether the citations are valid and from reputable peer-reviewed journals. So I think that's okay and well done. Maybe you can maybe write something on the overall assessment of the study. But I think this was a good session, and well done. Before I hand over to Teresa to welcome our guest editor, and so I'll just briefly comment on the reports. I think quite a number of you managed to submit reports, but also quite a number haven't done it. So we'll keep the forms open to just a few people. Okay, not a few. I think quite a number reached out requesting for an extension. So I think we will grant the extension just to allow you to submit the report comprehensively. The expectation is that the Google form that was shared in the emails is the one you should use to submit the report. There are people who are sending PDFs and Word documents just to the email. So rather than doing that, to make it easier for the teams that are doing the evaluation and just the assessment, just use the Google form that was shared. And the form, there are also people who are, rather than giving feedback, they'll just copy paste. Maybe if it's the abstract, someone will just copy paste the entire abstract with no feedback. I think maybe it was a misunderstanding, but make sure you maybe just read the instructions that we'll be sharing via email. So I think that's it for this part of this session, which was a discussion and appraisal. I think it was a very productive one, filled with learning for everyone. And yeah, we hope to see you next time. We'll share the next study design and the paper. The next journal will be a different one. And yeah, and we hope to have even more livelier sessions in the coming weeks. So I'll hand it back to Teresa, our moderator, who will then welcome our editor to make remarks, and then we'll end the session.
Thank you so much, Felix, for that session, and thank you everyone for your inputs during the discussion, the questions, the comments, the perspectives, and also the willingness to learn from one another. So at this point, I'd like to invite our guest editor, Dr. Ben Mutiso, to give us his remarks and also his feedback. Welcome.
Thank you for having me in this meeting, and again, thank you for choosing this article to discuss, which is work I did about 3-4 years ago. I must say that this was very productive. I mean, I feel that I have learned a lot. I have, if I were to look at if I were to do this work again, maybe there are some aspects I would do a little different. So this is how much growth you can get from this kind of sessions, and I would like to commend the team in the East African Journal of Neurological Surgeons for organizing this kind of sessions. So as an author, I feel this makes you better and better, and every time you write this again, you keep making it better and better. And also as a reviewer, it also sharpens my reviewing skills. So thumbs up to the whole team, and I look forward to participating in many more of such events. I would have responded to a lot of the questions, but I think it is better when you sit back and just and listen in and have, and see how people look at the work that you've put out there. Yeah, so I would like to thank everyone for attending and also for having me. Thank you.
Oh, okay. Yeah, I thought Teresa would close, but thank you so much for joining. It's been a very productive session. We'll extend the form. I think probably change the settings to allow people to submit another copy of their response. Just maybe if you've noticed you missed a lot of things, it's a learning experience for this first couple of sessions. There will be no grading, but a number of you also really did a great job, and perhaps you'll be contacted by the editorial team, maybe to be onboarded as some of the reviewers for our journal. And but we hope you'll keep participating. Just view this as a learning experience. Don't have too much pressure to be perfect, and just so that we sharpen our critical appraisal skills and peer review, and it really helps us think critically as we consume scientific literature. I think that's it from us at the East African Journal of Neurological Sciences. We'll see you next time in 2 weeks.